from the press? No, but just say we sent it. Say what time we sent it.
Okay, so Marie, why don't we, it is 5:09. Why don't we start with the roll call for REMAC and medical standards in order? See if we have a quorum. And then we'll do the housekeeping stuff, go to medical standards for David's report presentation and protocol meeting, and then finish with the REMAC component at the end so that we can streamline this process.
Okay. Okay, everyone, I'm going to be doing a roll call vote for both REMAC and medical standards. Just respond when I call your name. Grace Cacciola,
Here.
Glennis Seda, Bradley Kaufman,
Yeah.
Dario Gonzalez,
Here.
Nathan Reisman,
Here.
Pam Lai,
Here.
Nick Alexandru. Doug Isaacs.
Nick can't make it today.
Oh, Doug Isaacs.
Yep, and I'll cut off my ear here.
Thank you. I know Kevin Ward is running an exam tonight. Anne Marie Gregenti.
Here.
Thank you. Samia McKeechan. Allison Burke. Jeffrey Raybridge. Reed Caldwell. Jonathan Berkowitz. Louis
John
Marshall.
can't make it either. I believe John emailed you that he can't make it.
Yeah, he said he was going to be late, but he can't make it at all. Well,
He's clinical tonight, Marie, so.
oh, okay. Louis Marshall.
Present.
Michael Redlener.
I'm here.
Thank you. Dominic Battinelli. Efren Rendon, he's not able to be here tonight. Joseph Schenker.
Here.
Robert Ackerman.
Here.
Joseph Bove. Sean Graves. Arthur Cooper.
Sean Graves here.
Thanks. Art Cooper. Robert Winchell. Ed Jarvis cannot be here. Mark Cantor.
Here.
Thank you. Robert Krupe.
Here.
Thank you. Mary Foote or Timothy Stiles. Laura Ivacoli.
Here. Here.
Thank you. Matthew Fink or Wallace Carter. Eric Cohen. Kevin Munjal. Cindy Basilios. Adwa Smalls Mante. She's our new psychiatric physician. Matthew Harris. Jessica Van Voorhees. Ben Zabar,
Here.
Paul Barbara,
Present.
David Benelli, David,
I'm in one of the
You thought a
boxes
wave
over
would
there.
work.
I've got
You
to
have to
hear it.
verbalize, David.
Peter Wire,
Here.
Yadidya Langsam,
Present.
Tony Shalish. Okay, now we're going to medical standards. Some of you will hear your names called again. Just answer again.
Do we
Paul
have a
Barbara.
quorum, Marie, for REMAC?
I'm not sure. I mean,
Let's
it's
find that
not.
out first.
Yeah, I'm not sure either, just from the,
Yeah, let's see. 1, 2, 3, 4, 5, 6, 7, 8, 9, no, 8, 9, 10, 11, 12, 13, 14, 15. Yeah, quorum is
I believe the quorum is 19.
quorum is, yeah, we do not have a quorum, but these people are REMAC, so they may come in a little while.
Marie, do you have Glenn? He texted and
You're
said,
muted, first of all.
I'm sorry?
Glenn said he said here, but I didn't hear him. I don't know if
Neither
you
did I.
got
Okay.
him. Glenn, are you here?
Yes, I'm here. I'm sorry. I was having technical problems with that *6 damn thing.
Okay.
Okay, can't do any business whatsoever until if you don't have a quorum.
we
So
still can do medical standards, right? At least, and see
that's
if anyone
what I'm
else
saying.
joins.
There's something is not REMAC. That's correct.
14, 15, 16, 17. Okay, looks like we have 18 positions. We're one short. Let's go to medical standards and at least run that committee. Let me do attendance for that. Maybe another doc will show up. Paul Barbara,
Yes, off mute. Hello.
thank you. Cindy Basilios or Harry Koplovich. Joseph Bove. Nail Semilovic. Wallace Carter. Robert Krupe.
Here.
Lauren Costurco.
Here.
Reed Caldwell. David Lobel or Matt Friedman. David Eng. Jeffrey Raybridge. I thought Jeff was here before. He was.
I don't think he was here before.
Okay. Michael Redlener.
Present.
Thank you. Joseph Schenker.
Here.
Anthony Shalish. Rafael Torres. Jason Zimmerman.
Here.
Great. Nick Alexandru. Glennis Seda.
Here.
Thank you. David Benelli.
Here,
Dario Gonzalez.
Here.
Doug Isaacs.
Here.
Raybridge is coming.
Hmm?
Raybridge is coming.
Okay, great.
Sorry. That
No,
makes a
it's
quorum.
Good.
Here.
Okay. Anne Marie Gregenti.
Here.
Okay, great. Thank you. Grace Cacciola.
Here.
Maddie Fong.
Present.
Sean Graves.
John Grace present.
Thank you. Okay, and Robert Ackerman,
Here.
Morty Lax,
Present.
great. Art Cooper, Yadidja Langsam,
Present.
Lewis Marshall, I know Lou's here. Kevin Munjal, and Jessica Van Voorhees.
Present.
Oh, great, Kevin, good.
Okay, Marie, it looks like Tim Stiles and Jeff have joined us, so I think we have a quorum for REMAC. But just if you can add them to the roll officially, that would be great.
Okay, Jeff Raybridge,
Yep, here.
thank you. And let's see who else worked in.
Add also Kevin Munjal, I think he'll,
Yeah. Okay, Tim Stiles.
Yeah, I think she just got me.
Okay, Kim. Okay, so we have a quorum now. The REMAC, we can get going.
Okay, so let's begin by approving the minutes from the last REMAC Medical Standards meeting. Does anybody have any questions about the minutes? Hearing none, I'll entertain a motion to approve. Okay, great. Yadidja has a motion to approve. Second, somewhere?
Second.
Great. Anyone have any, besides doing a roll call or anything like that, is there anybody who opposes to those minutes? Hearing none, we'll move on. The correspondence report, just some enforcement actions that we have to read into the REMAC minutes. I'm going to read this. I'm going to butcher it. Andrew Tsitzikowicz, 467560, probation 3 years, effective 12/17/2021. John Henderson, 143456, revoked effective 2/3/21. And enforcement actions can be viewed on the DOH website as well. The following advisories were issued. 2021-04, which is the 2022 protocol revisions. 2021-05, which is the change of the revision date to 2/13. 2021-06, Omicron COVID surge shortening of quarantine, which was issued on 12/6. 2020-09 was reintroduced as the advisory of the viral pandemic protocol. And then 2020-07, which is the temporary staffing standards, was reissued as well. That is the correspondence. Does anybody have questions about that correspondence? Okay, hearing none, I will move on to committee reports. I'll start with the executive committee. The executive committee met shortly after the CMAC meeting last week to review and approve the updated viral pandemic protocol that came out. There were some minor changes made to the protocol, removing the age, putting a date on it in terms of how long it can be in place before it needs to be revisited by the REMAC. And that was approved by the executive committee, but I think it would have to be voted on by the REMAC body to approve it as well. Being that the pandemic protocol original was already, I will entertain it as a reverse motion, being that it's seconded from the executive committee. Is there anybody on this call that opposes the new viral pandemic protocol being released? Okay, hearing no objections, Marie, we can accept that as a unanimous approval. Okay, that's the executive committee. We're going to go now to medical standards, and then we will come back and finish REMAC afterwards. Yes.
Sorry, it's Brad. That has to be reapproved every, do you want to talk about?
So once it's active, it needs to be every 14 days, I believe, is the date on it. The executive committee would have to reapprove it. So in 14 days from, I believe it was, we met on Wednesday. So not this Wednesday, but next Wednesday, which would be the 19th, we would have to reapprove it, and the executive committee will reapprove it if necessary. If not, we will have a discussion with the rest of the group. But that will be the process going forward every 14 days based on need. Hopefully, if all goes as is suggested, the 20th, we should start seeing some relief with this wave of COVID. Any questions about that?
Can I just ask, I was not at the CMAC. Whoever has a copy of this final version, please email it to me so I could send it out.
Yeah, I think Jeff does, but
Yep, I do. And if I don't, I know Lou Marshall has the original copy, I believe.
Okay, great. Thank you.
Yeah, now that still has to be approved. The changes still have to be approved, I think, by the
Commissioner.
Yeah, before they're actually active, but I don't think there's a problem with the region. I don't think there's a problem with the region implementing it.
right. Okay.
Just for clarity's sake, there was something circulated that was basically a reissuing of the one from last year. So is that one's active or is the new one active?
Yeah, so the one that was originally sent out was the old one. That was changed at CMAC, which happened after that reissuing, which basically removed the temperature criteria of 100.4, which essentially would send everybody to the hospital and really make this a useless protocol. There are a few minor tweaks to it as well, but that was the major one. So what I would say is that we will re-release it. Again, the executive committee met, approved it. We'll send it out to the committee if anybody has any questions about it. It is the new statewide viral pandemic protocol, so it's not like we could continue to use the old one. The question would be if anybody felt that we didn't want to use it at all, then we would discuss that to remove it from our region completely. But as of right now, I think we're good for now. Ben, you have your hand up. You're muted though.
Yeah, just one thing is it does say for patients who want to be transported, it's up to the local policies. I don't know if you want to have someone make a motion that that decision about whether to, overrule the patient or to require the crew to call medical control should be granted to the agencies implementing it.
So we did begin that discussion. I think that's a very slippery slope. It would lead to very different standards in the region. So for right now, it would still be a medical control decision. It's not an agency specific decision. But the protocol is as is, which is if a patient is required to go. I mean, every agency medical director and every medical control has the ability to refuse a transport. It's up to them to do that. But I would say that the protocol stands as is right now. It can't be done without medical control in that situation. But that
Joe, can you clarify for me? Oh, sorry. Excuse me. Can you clarify for me just with the FDNY ops order? Was that with? What was the ops order specifically, and what did it say?
So versus... I'll let Glenn talk about the ops order, but the ops order refers to the pandemic protocol. So the ops order is how the fire department operationalizes that protocol. Glenn, do you want to speak to that?
Sure. Yeah. I mean, that was what was in place at the time. We knew that we were going to try to see if they can tweak it at the state level. So that is as is at the moment.
Understood. Thank you.
Okay, good. Let's proceed with medical standards.
Yeah, I just want to make one point on the protocol to Lou's point also is that those revisions that you see in the new version still have not been approved by the commissioner. So just so that everyone knows, it's not final.
So what does that mean? So what does that mean? Can we use
it means
or
that
not?
the original pandemic protocol is not superseded by this new protocol until it's approved by the commissioner, is my understanding. I don't know, Lou, if you have a different understanding, but it needs to be signed off on by the commissioner.
Yes, that's my understanding as well.
Yeah, that's my understanding.
But we can clarify.
Yeah, I mean, actually, Jeff had asked Ryan Greenberg, in fact, to see if he could speak with the commissioner to try to expedite it. So I think that sort of furthers that point.
So there's no timeline as to when this would be signed?
No, but I did, as was just said at the CMAC SEMSCO meeting, I did ask the director to for an expedited protocol for that. So they didn't give us a timeline, but they did say that they anticipated quick action on it. What their version of quick is, I don't know.
Unless the chair of the New York City REMAC wants to reach out to the commissioner directly.
Sure. I think that's fun. Let's go with it.
Yeah, honestly, I think we should. Stir the pot.
Excellent. We will reach out directly.
Dr. Doy now also has a meeting scheduled with the new commissioner, so we can see how that can help.
Yeah, Joe, I think that meeting is scheduled for next week, so you might want to touch base with Don before that.
Sounds good. Okay.
We would like this to be approved, obviously, when it's still relevant to New York City.
Or relevant to the state in general, right? By the time it's approved, it may no longer be needed. So that was our point. You're right.
Can I ask the question? I mean, in the past, we've approved stuff for regional use and apologized later. So if we really need it in New York City, if this group really wants it to go forward, then we should.
Well, what was interesting to me was that at the CMAC rather, there was an extremely long discussion about this protocol. I mean, this took up a tremendous amount of time. And a few physicians there, not surprisingly, wanted to know why New York City jumped the gun, who gives them the right to do what they did. But a lot of other physicians, and I thought the majority said, well, if New York City did, we should all do what New York City did. And that was something new that I hadn't seen that type of support for a long time on the CMAC. So there was some interesting things that happened at the CMAC, including an attempt by the state, by Ryan particularly.
Hold on, guys, we're going out of order here. There is a CMAC and a CEMSCO report. I'd like to get to medical standards because otherwise we'll be here till tomorrow. David.
Good. Okay, so we voted to approve so good evening, everyone. Thank you for joining. We voted already to approve the joint committees minutes. Let's start with the subcommittee reports. Dr. Barber, let's start with the Cnc report. I know that you have sent out some new changes, right?
Yeah, so thank you, David. Just see if I can pull this up real quick. Charlie or Joe, did you guys have any chance to throw up what I just sent out? All right. So anyway,
Charlie, can you add Paul as a co-host?
That's all right. It's not going to. Well, if you make me a co-host, it'll be a little bit easier. I did want to share something with you guys for tonight.
Thank you. All right, Paul, you have the ability now.
Okay, so just a couple of pieces. I know the paramedic exam is a big sticking point for everyone concerned about protocol changes. I hear it a lot in my agency, as well as Kevin's getting a lot of conversation. The memo had gone out that the transition point for the 2022 protocol update is February 13th, 2022. I know there was some question about which protocols for people to study. The reality is, we say this every time, the medicine really doesn't change too much. It's more tweakings of the protocols. So if you know the medicine, we have full confidence that you'll pass the test. What you're going to do in the transition point, because there is a couple of iterations of the protocols, Kevin has agreed to, on any failure, basically review to see if there's a discrepancy that's something that could be caught between the 2021, 2022 protocols. And if so, just remove that question from the person's score in an effort to have equity and fairness for the exam to be a metric for a standard of knowledge of the regional protocols, not necessarily to get people stuck on things. So does anyone have any questions about the paramedic exam with that piece? Excellent. One of the pieces, the medical control credentialing at the end of the year. Just wanted to say, I think this was a rousing success. Thank you to everyone who's been participating. We have gotten several different providers credentialed, and the different course instructors are all kind of aligned at this point. And thank you to the course instructors. I'm not going to put up statistics about the exam because the exam is out, and the exam is now new. We have I'm just going to share this little piece here. Hold on. That's what I want. All right, can people see my screen?
Mm-hmm.
Okay, so this report page here, we discussed the paramedic exam already. For the medical control credentialing, the process is the same. The Form 1 fills out for the student who's taking the test. Form 2 is the actual exam, and Form 3 is the attestation. The course instructors seem very confident with this piece. I just wanted to discuss that the new exam, we actually broke down the exam into percentages, and the test is 40% GOP, 40% protocols, and 20% appendices. Most of the medical control pieces are really those GOP and appendix pieces. Instead of it being very heavy on the clinical medicine, it's about the things that are particular to the EMS region. And you can see that we have a breakdown of what each section is: critical, general cardiac arrest, general medical, trauma or hazardous materials. And you can see the breakdowns there. The bulk load of the protocols are going to be on the general medical, with some focus on the critical and the trauma and the hazmat. So does anyone have any questions about the medical control test or the essentially this question bank with all the questions kind of pre-correlated? All right, we have one person who took the test so far and they passed. Yay. I'm going to stop sharing that so people can look back at the matrix here. Third piece is the telemedicine credentialing process, which Kevin, myself, Nick, some of the people have spoken about offline. I did want to bring up here that we are trying to build out a process for the telemedicine physicians. And currently they're being kind of shoehorned into the medical control process. And without, I put to the committee here, maybe we could break off in a small group or have, some feedback about what the ideal way to credential telemedicine docs are. Not necessarily for telemedicine docs, but more for the future in case other physicians get involved in our region. For instance, neurology a couple of years ago, I see the future with Ecmo potentially. We should be the body that governs physicians who are not necessarily EMS trained, who have an EMS function. So open the floor for discussion about the telemedicine credentialing process.
Okay, any thoughts from anyone?
I'll just echo what Paul said. I mean, I think, we've talked offline. I agree that, I don't actually feel that there's a huge problem with shoehorning the way we use telemedicine physicians into the current process, but I agree that we need to think as a committee if you have, I think a few years ago, the stroke example, we just sort of tried to quickly shoehorn them into the telemedicine process, even though the telemedicine process stipulates it has to be established patients. And then I think there's an open question that was brought up during the ET3 discussions as to what, if any, credentialing should a physician doing ET3 do. So I think there's open questions to consider for this body to think through.
Yeah, these are open questions. They're important questions. Paul, do you want to form a tag about this, or how do you want to proceed with this?
What I'd like to do is to have a distinct pathway for the telemed doc, and I just I think it's what they deserve, and I think it is a unique field. We have it in our GOP that they're a non-REMAC OLMC certified physician. I think there's got to be either a discrepancy, either a lower threshold for the exam, or a different exam at that point, or people don't feel strongly about exams, but I just I'd rather if we're going to have pull down menus for the telemedicine track, I don't know what that is, and that makes my obsessive compulsivity go into a frustration zone.
So, how do you want to come up with a suggestion and bring it to this committee? Unless you want to bring some more people on board and have a discussion and then come.
Well, is anyone interested in helping out? I mean, the big ET3 programs would be ideal here because this is not really a 911 heavy thing. Nick has been extremely helpful from the fire department end with the medical control piece. I think this is more of the telehealth, telemedicine piece. Unfortunately, Berkowitz isn't here tonight. I'm sure he'll want to be involved, but you know, for the programs in the area that are doing this type of function, I'd like to have their input so we could craft something that's suitable to the process that they need.
Okay, so in the interest of time, Paul, can you reach out to individuals
Sure.
who you believe would be interested in this, and see if we can come up with some sort of plan and bring it back to the committee?
10-4.
Does that sound reasonable? Okay, good. So let's move on. Thank you, Dr. Barber, and thank you for all the hard work that you're putting into this. You bought the CNC committee and credentialing process.
I'm on 2 calls.
Way ahead.
I'm on REMAC and I'm on the
Laura,
COVID
you need to mute yourself. Laura, just mute yourself. Good.
Did it already.
Thank you. So thank you very much, Paul, for all the hard work that you're doing with the credentialing committee. Next, let's move on to the protocol committee. I believe that there are 3 items that are going to be brought for vote over here, both by medical standards and REMAC. So I'll open it up to Dr. Lai to present, please.
Okay, great. Yeah, so I will, I'm going to just share onto my screen. Hopefully you guys can see this on my screen now. A lot of these are going to be just some language clarification changes, just to a few select protocols that will that'll just kind of like walk through with it. The first one was just a clarifying statement to the GOP section. This is to the definition for discretionary orders. This was discussed at the protocol committee earlier on in October, where there, as you can see on here, that there's just a phrase that's just added on here for the discretionary orders, just to clarify it, that discretionary orders are going to be coming from a REMAC OLMC certified physician. Otherwise, everything else in terms of the definition remains the same in terms of what a discretionary order is. It was just a clarifying statement as to who that discretionary order will be coming from. And that is the change that the first change that we have to go over tonight.
Okay, very good. Thank you, Dr. Lai. So any discussion about this? It's hard for me to see who is raising hands here.
Hey, David.
Who is this?
This is Kevin. I have a comment.
Oh, Kevin, yeah, go ahead.
Pam, is that intended to me? Because I think I have to go back and look at the definitions of the telemedicine certification physician, but are you intending it to not be available to a telemedicine physician?
Yeah, so I think that, you know, what we have right now in terms of all the different physician levels, the telemedicine physicians, at least right now, like they're only able to do things like for their own providers. I think that this one was just sort of the blanket statement in terms of like the discretionary orders for the regular providers is going to be from the REMAC OLMC physician.
So for clarity, you know, right now we do a lot of discretionary orders from the REMAC certified telemedicine physician. So that would be a major impact on us. I don't know if that was intended or not, but you know, I would certainly need to. Yeah, I want to make sure the group is aware, and I'm not sure that that's the intention from the whole group.
So I think if we want to make an amendment, that we have to make that it has to come as a formal request. Then is that right? If we want to change that definition, is that right, David?
Kevin,
Yeah, I'm happy to make a motion. Just trying to
this
clarify.
comes forward as a seconded motion from protocol. So Kevin can make a motion to amend it, which would then have to be seconded, discussed, and voted on before we could vote on the original motion.
So Kevin, do you want to just add wording over here that would accommodate for your telemedicine docs?
I know we recently changed the language that Pam's referring to about the different physician levels. So I'd have to go look it up and cross-reference, but I would think that from a REMAC certified physician would perhaps be sufficient for the purposes that the protocol committee is looking for.
So Kevin just is suggesting to just remove the OLMC and say REMAC certified. Any discussion on that? Charlie, maybe you can make me co-host as well. I'll see if anyone's raising their hand because right now I can't.
You can unco-host me if you want.
It's fine. I guess we can have plenty of co-hosts. Okay, any discussion about this?
Dave,
yes, who's raising their hand here?
It was me.
Okay, go ahead.
Is anyone else in front of me?
Oh,
No,
you're the only one.
So we've talked about this a lot, that if there's going to be, it's kind of a decent segue from the last piece, that, even from the credentialing level, if there's going to be different scopes of practice, there's going to be differences in what they can do. That's kind of definition. So, I think we as a group just need to come to an agreement, like, are they different or are they not? And if someone needs to be up-trained to the level of a REMAC OLMC certified physician, that's what we have a process for. But if we do have discrepancies in the types of physicians that we recognize, as I'm looking at it in the GOP right now, there will be differences. And that's what those differences are the rights of the protocol committee and the medical standards committee to forward up. But I actually agree with this. And I would go so far as, I advise strongly that any of the medical control docs in my agency never use a discretionary disorder because of safety, so I actually agree with this.
Kevin, for what situation would your doctors actually need to use discretionary orders?
Well, so basically the physicians in our program, first of all, to clarify everyone's recollection, they do everything, they do all the same certification minus ATLS, the external trauma certification course, and PALS, right? They're going all the way to that standard, right? Following all the other training criteria. And of course we should revisit this, and that sounds like what we're going to do. But so part of the purpose of going through all that was so that these physicians can work with the medic, utilize the formulary to manage the patient as best as possible. And so they are making, not infrequently utilizing a medication, possibly for purposes not specifically delineated in a protocol for a specific condition.
Can you give us examples of when that would happen?
If somebody's having some kind of reaction that sounds like a dystonic reaction, that's a common thing that we list as we give Benadryl for.
Okay, any further discussion on it?
Sorry, I'm having trouble finding the hand raised sign for some reason. It's Doug. I agree with what Paul had, his comments. Kevin, just so I'm understanding, are you, because this, if it's to the telemetry physician's own units, then they could do discretionary orders, but you just want kind of carte blanche where, can you just clarify that? Because I was a little kind of confused with the requesting. Thank you.
So the only difference right now between a telemedicine, as I understood it, from a telemedicine physician to a OLMC physician, having gone through all the training except for ATLS and PALS, was that for their own patients, they could utilize, they could give orders to the medics. That includes a discretionary order, which might be changing a dose of what's in a protocol, right?
Okay, I see that there are two people that have their hands raised. I believe Ben Zaber and then Paul Barber, and then Robert Ackerman.
Just on page 3 of the GOPs, it already defines REMAC telemedicine that it's only for treating their own patients and 911 ambulances. So if this language here, if that online medical control word got deleted, it would not, as I'm reading it, expand the ability of telemedicine docs to give orders to 911 units or their patients who are not their own patients. So I don't think making the change Kevin suggests is going to expand, from what they're doing. No, I know, but I think that's people's concern that would, if it's, I think Kevin's suggesting making a change, and I think some people are concerned that change may broaden the ability of telemedicine to issue discretionary orders, but from what's on page 3, that already limits their scope.
Excellent, thank you. So Robert Ackerman, then Yedidia, and then Michael, and I want to close the discussion after that and vote on the motion.
I put my hand down, but I have my hand up. Can I put it down when you recognize me?
Okay.
We can't craft protocols or use guidance here for or against any particular agency. This is a multi-agency meeting. So we would say it the same way if it was another way. This is not for or against any one particular agency. We need to be crafting the best decisions for the region. There are a lot of telemedicine issues. I would make a motion that we set up a telemedicine tag and have the interested parties hash out these issues rather than dealing with them here.
Okay, but let's first finish discussing Kevin's motion. And then we can move on. Okay, Robert Ackerman.
Sure, just to echo from Dr. Munjal as a provider. So some of the examples that we've seen are fluids outside of the protocol, and for instance, larger doses of, let's say, Zofran would be a good example. But as was discussed, if it's only for the telehealth physicians, then I see it. But I also agree with Dr. Ben-Eli that it does need to be across the board for the other agencies as well, like Dr. Schenker on the interfacility side.
Well, that's what I was going to bring up, David, is that, when we discuss these protocols, we really have to consider that the REMAC protocols as they are really designed for emergency care of patients rather than interfacility or community paramedicine type of situations. A private doctor who is doing community paramedicine on his own patients, by law, is allowed to do whatever they want for a patient. And as long as it's not out of the scope of practice of the paramedic, we really can't prevent them from doing that. Meaning, as long as it's not having somebody do something outside of the scope, we can't prevent them. We can prevent them from doing things when they're treating patients in an emergent fashion or in an acute fashion. But the same way that a hospital can transfer a patient from one place to another, and the doctor in the hospital can provide orders for, standing orders or provide instruction to the paramedics as long as it's not out of the scope. I think maybe we're getting into the point where we have to clearly differentiate between emergency care, whether it's 911 emergency care, volunteer emergency care, an emergency from a proprietary ambulance, and interfacility or community paramedicine as a different, I wouldn't say standard, meaning the paramedics are performing to the same standard, but they're being expected to do different things.
Understood. So how would you propose to do this in this GOP section?
So I think that this is maybe broader than this discretionary order sentence. Maybe what we have to do is define the scope of these protocols to emergency care in our region versus the interfacility guidelines as the basis for interfacility transports, and maybe put language specifically geared towards community paramedicine or ET3, specifying how we see that playing out. I just think that we're so, in our protocols are the language, the law of the land, but there's so many things that happen outside of the scope of the emergency protocols in pre-hospital care in New York City that we need to have an accounting for that. We're not specifically going to tell everybody exactly what to do, but we have to be able to define it. So whether it's saying that, a interfacility, a community paramedicine physician can, advise as long as it's not out of the scope of their practice. I'm not really sure how the best language is, and I don't know that this one line defines it. Actually, when you say a REMAC certified or OLMC certified physician, I don't know that that's really, we're limiting to very specific things, this discretionary order category, which is really just using a drug in our protocol out of the standard of the protocol. I don't know that really is doing significant changes here. Does that make sense?
Okay, so I think that we have to divide this into two separate issues. The more general issue as to the applicability of these protocols and GOPs, which I think is a separate discussion.
Correct.
And which needs to be done and clarified, and we can bring this back to the committee once that discussion is done. And the specific question about changing the definition of discretionary orders this evening here. So there's the motion of Kevin to remove OLMC from OLMC certified. There are two more people who are waiting to talk, and then I think we're gonna start voting on this. Yedidia, Dr. Langston.
So I agree very strongly with both of what Dr. Schenker said and what you just said, because simply removing it from here is a very slippery slope. The next thing you're going to see is that any physician anywhere is going to already stop being able to give discretionary orders. And that's specifically why we put this in here in the first place. Just like interfacility has their own protocols and you have a special committee to work on that, I believe that community paramedicine now needs to be separated out, as you said, not emergency medicine, separated out with a special paragraph or chapter or even a set of protocols. But I think it would be very dangerous to remove that clause over here, because remember, we once had that problem where physicians from particular agencies would come on the scene and try to give discretionary orders. And you know which agency I'm talking about without mentioning them by name. And it's happened all the time. And there was big issues. So we put that in there on purpose, and I think it should stay there.
Thank you, Dr. Langston. Dr. Redliner.
Yeah, thanks for recognizing me. I think in general that I agree with what Dr. Schenker is saying, which is that this is a larger discussion. I think that I don't have the language of the telemedicine physician in front of me, but from what Kevin quoted, I think that it should already be taken care of in that the description of the telemedicine certification. And so, I think that, it's probably reasonable to follow the motion that Kevin is proposing to take out OLMC certified. But in general, I would just table this and make it part of a larger discussion. That's my feeling about it. I think that it's something very specific for a larger issue that we need to address.
Okay, thank you, Dr. Redliner. I don't think I'm going to lower all hands unless someone else has any other further comments. Please raise your hand again. I think that we can address it in the larger picture. I agree. I think that we should probably take care of the motion that's on the table right now. Both motions, first Kevin's motion and then the protocol committee second motion, and then we can bring it to a further larger discussion in a future time. Kevin brought a motion to strike out the OLMC from the REMAC OLMC certified position. Is there a second? Is there a second for that motion?
I second it. Redliner.
Okay, very good. So I'm going to let Kevin talk because he raised his hand before I asked that question, and then we're going to vote on this. Okay.
Thank you.
Kevin, go ahead.
Thanks so much. I just want to clarify that this was brought forth as sort of a clarification, and the clarification, so that we're all clear, right, is that we're all asking for physicians to go through a certification process to the highest standard to be able to use these discretionary orders, and the current standard is that, right, without making any before all the changes we want to make, which we need to have the bigger conversations. The immediate impact of this is to suggest that somehow, all the reasons we put forth this telemedicine certification several years ago are no longer valid, right? The reasons we put together that whole process was to figure out how to safely enable a group of physicians to provide orders to 2 paramedics on non-911 calls for their own patients. So this slightly, not slightly, this undermines that. So what I'm saying is that the correction I'm making is simply to accommodate both the need for clarification that was requested, as well as be inclusive of the already existing telemedicine physicians who meet a very high standard.
Okay, very good. Thank you, Dr. Munjal. I think that we've devoted enough time on this discussion over here, and we should move forward. So there's a second in motion to remove the OLMC from the REMAC certified physician, from the REMAC OLMC certified physician. There was a second in motion. Let's please just, I'm gonna just do a vote. Let's just do a roll call on this, Marie, please, and allow people to vote their opinion. Marie?
Okay, we do roll call votes in REMAC.
I know, but it's going to be. I don't want to. I want people to be able to say. I'm not sure how people are going to vote. It's not like everyone is going to vote for or against. So let's just go to the list of people.
I'm sorry, could you just restate the motion quickly, what we're voting on? I'm sorry.
So there is a second in motion being brought regarding from the protocol committee to add to the discretionary order GOP the sentence from a REMAC OLMC certified physician. Kevin is amending that, requesting to remove the OLMC from that sentence. Okay, that's what we're voting on right now, whether to remove the OLMC or not from that sentence.
Okay, thank you.
Okay, just give me a second because I have to, I don't have any REMAC roll call sheets. I mean, medical standards.
Medical standards.
Yeah, I only have it for.
David, do you want to do hand raising? We could raise hands.
No, because it's hard for me to count the hands one way or the other, and let's just do this for clarity, okay?
Okay, sorry, just give me a second. Okay, and let's see if this works. Come on, machine. Okay, so please answer. And this is a vote on. Well, you're gonna have to reword.
Okay, a vote on the amendment to the protocol, to the change brought by protocol committee. Protocol committee brought to medical standards a second in motion to add to the discretionary order, GOP discretionary order, to add a sentence from a REMAC OLMC certified physician. Dr. Munjal, and seconded in motion by Dr. Redliner, wants to remove the word OLMC from that change. That's what we're voting on now, whether to remove OLMC or not.
Okay, so when I call your name, please just say in favor, oppose, or abstain. Okay, Paul Barbara.
What were the choices again?
It's not clear. It's what is the actual vote for right now?
The
Maria?
vote is, okay, please, guys, let's do this, repeat
I
this
had to
the
go
third
first.
time. Yes, let's repeat this the third time, and just to make it clear. The protocol committee is bringing a change to the GOP section to the discretionary orders, and I apologize if I'm sounding impatient, where we're adding to the discretionary order that a discretionary order has to come from a REMAC OLMC certified physician. That's what is being proposed by the protocol committee as second in motion to be entered into the GOP. Dr. Munjal made an amendment that was seconded by Dr. Redliner to remove the word OLMC from that change. That is what we're voting on now, whether to remove the OLMC or to leave the OLMC. If you're in favor of removing the OLMC, you say yes. If you're against removing the OLMC, you say no. And if you're abstaining, you're abstaining. Now let's continue with the vote.
But David, isn't it two different votes though? I'm sorry, I'm not trying to be difficult, but isn't that two different votes?
I'm
First
voting on-
vote is-
Yes.
We're
Right now, you're
voting on
just
the am-
voting on removing the OMLC. You're voting on
Correct.
the amendment.
Correct.
We're voting on the amendment. We're not voting.
If the
Later
amendment
on, we will
passes,
vote on the
then
whole
we'll have to vote on the
sentence.
regular.
Yes.
Okay, so vote on the amendment right now. Sorry, Dr. Barbara, you're still the first vote.
You ready?
In favor, opposed, or abstain?
Oppose.
Okay. Cindy Basilios is here. Okay. Joseph Bove. Neil Semilovic. Wally Carter.
Oppose.
Opposed. Okay. Dr. Krupe.
In favor.
You're in favor. Okay. Jeffrey Douglan. Lauren Kosturko. I'm sorry? Did you say
Opposed.
opposed?
Yeah.
Thank you. Reed Caldwell.
Abstain.
Abstain, okay. Jason Zimmerman. Dr. Zimmerman.
Oh, I abstain.
David Lobel. Or Dr. Ng. Or Dr. Friedman. There. Okay. Dr. Raybridge.
There's a spoon in there.
Opposed.
Computer. Michael Redlener.
In favor.
Okay. Joseph Schenker.
In favor.
Anthony Shalish. Rafael Torres. Nicholas Alexandru. Glenn Seda.
Opposed.
David Benelli.
I'm the chair. I'm gonna vote
Wait,
yes.
the last, okay. Dario Gonzalez.
Opposed.
Whoopsies. Doug Isaacs.
Oppose.
Bradley Kaufman.
In favor.
Marie, this is Art Cooper. Did you get me?
No, not yet. Okay,
Okay.
now this is medical standards, so I'm asking the entire committee, physicians and
No,
non.
you're asking, yes, you're asking medical standards, yes.
Okay, so this is non-physicians included. Anne Marie Grigenti.
I thought that on medical standards, we ask physicians to vote. But
No,
maybe I'm
Medical
wrong.
Standards is everybody.
Okay,
REMAC
go ahead.
only positions.
Oh, dear God.
That's a strong opposition over there, Anne Marie.
Yeah.
Anne Marie.
Anne Marie, I'm sorry, I didn't mean it.
So in favor. Okay,
Now Benelli thinks barking is okay. Okay, thanks, guys.
Grace Cacciola.
In favor.
Okay, Madeline Fong. Maddie, you still here? Sean Graves. Sean? Robert Ackerman,
In favor.
Morty Lax,
In favor.
okay, Arthur Cooper,
Opposed.
opposed?
Yes, opposed.
Thank you, got it. You did your Langston? I think Dr. Langston had to leave. Okay. Lewis Marshall. Dr. Marshall. Kevin Munjal.
In favor.
And Jessica Van Voorhees. Okay, so give me a second, I will give you a count. Okay, Maddie's texting me, she's in favor, her audio is on the fritz, okay.
Dr. Marshall in favor. Sorry, I couldn't get my audio up.
Okay, so you're in favor. Sorry, just give me a few minutes. Favor. Now, if you want to start talking about something else while I do a count.
Let's just wrap this up because we still have to vote on the
Okay.
on the original proposal for change.
David, I know Maria is still counting, but I would like to move to table the original motion to protocol as part of a larger discussion.
1 minute, Joe. We're in the middle of voting. Okay, so.
Well, that vote is done. Maria's just counting. But
Okay, I think that we can complete the vote on this and then have the more general discussion.
Well,
I don't think that we need to.
Is there a second to move to that motion?
I second it.
Thank you.
Redlener.
Then we vote on it. There's no discussion on a tabling motion. We have to vote to table it. If it gets tabled, it goes to the next protocol committee for discussion. That's Robert's rules. So Marie, when you're done, we'll again, if anybody is against it, we'd have to go roll call. But if everybody is in favor, we can move it. But if anybody's
Okay,
against it, we have to do a roll call of medical standards.
Eight opposed, 10 in favor, and two abstentions.
So that motion would
Okay,
pass.
so that motion would pass. So do you
Correct.
still want to table it, or do
I
you
would
want
like
to
to
vote
table
on this?
again, the next CMAC is not for a while. We have plenty of time to discuss this. I think this is part of a larger discussion, which is why I'd like to table it to protocol for them to discuss it as a bigger picture, and then we'll bring it back when it's formalized in that bigger picture. That's my tabling, my rationale. So now we vote on the tabling. If it is in favor, it gets tabled to protocol.
Okay, so let's please vote.
Do we need a roll
Okay, so I'm
call?
gonna.
Yes, unfortunately.
Yes.
Unless it's
Unless no one
unanimous.
objects.
If it's
Or
unanimous, if
abstains.
there's no objections, then we can vote as in en masse.
Well, I think that if we can make the roll call faster, I think it will be very beneficial, because I want people to be able to vote one way or the other.
Agreed.
So what am I doing? Am I doing a roll call?
Roll
vote?
call.
Roll
Yes,
call
please do a
vote,
roll
Marie.
call. Yes.
Okay, so this is voting on.
This is moving the
tabling.
table back to protocol.
Okay, and this is table. to protocol. Okay, Paul Barbara. Sorry, Paul. Table or not to table?
Not to table.
Okay, so that's opposed.
Opposed.
Yeah, opposed. Wally Carter,
Table, please.
getting myself confused. Dr. Krupi,
Table.
that's in favor of tabling. Okay. Lauren Kosturko,
In favor.
Reed Caldwell,
In favor.
Jason Zimmerman,
In favor.
okay. Jeffrey Raybridge,
In favor.
Michael Redlener,
In favor.
Dr. Schenker,
In favor.
Glenn Asada,
Yes.
Mario Gonzalez,
In favor.
Doug Isaacs,
In favor.
Bradley Kaufman,
In favor.
Anne Marie Gregenti,
In favor.
Grace Cacciola,
In favor.
okay, Madeline Fong, in favor. She just texted me. Sean Graves, Robert Ackerman,
In favor.
Morty Lax,
In favor.
Arthur Cooper,
In favor.
thank you. Louis Marshall,
In favor.
Kevin Munjal,
Sure,
that means in favor?
in favor.
Okay, I don't even have to count for this. This is.
Thank you. Okay. So very good. So this is table being set back to the protocol committee. Let's move on to the second motion from the protocol committee. Dr. Lai.
I'm sorry, David, the tabling does, I don't think it sends it back to the protocol committee.
You can table it to a
Excuse me?
specific place, Brad. So
Right, so
you
it
can
just
table
comes
it
up
to-
at the next meeting.
You can table it to a specific committee. It's a subcommittee of this, of this one. You can table it to that committee.
Okay, I'm not,
If you just say you
Yedidia is
want to
not
table
here.
something, then it comes back at the next meeting, Brad. If you
Yeah,
table
you
it
could
to
definitely
protocol,
table
it's
it.
okay.
You could
Sounds
table it
good.
to protocol.
Good, sorry.
No, it's okay.
Okay, let's
Okay.
move on, Dr. Lai, and hopefully we won't have extensive voting over here and we'll be able to move on.
Okay, so the next one up is some language changes to the pediatric severe bradycardia protocol that you can see here. This one, again, I think that this came about after, kind of going through with some of the training for this protocol, that there was some confusion in terms of when to ventilate pediatric patients versus when to start CPR. So hopefully that these language changes were made to help clarify this. So you can see that there are changes here in terms of the addition for the ventilate for 1 minute. And then if that heart rate is less than 60 beats per minute, then to start chest compressions and ventilations as per the AHA guidelines. Afterwards, providers would be checking pulse for every 2 minutes. And then if the heart rate is between the 60 to 100 beats per minute, and if the patient is not breathing adequately, then they are to assist the ventilation for that. If the heart rate is greater than 100 beats per minute and breathing adequately, then they are just to administer oxygen via the non-rebreather mask. There are also just an addition over
Go ahead.
to the key points section on here too, just to add on to the key points that to evaluate for evidence of ingestions for beta blockers, calcium channel blockers, and treat in accordance with OMC protocol. So those were the additions on there.
Okay, and this was written by Doctors Harris and Zabar, correct? So we
Yes,
had
that's
pediatric
correct.
input here. Okay, any
Yes.
discussion about this, the changes to this protocol?
Yeah,
It looks like
it's
Ben
Amber.
has his hand up.
I'll just say
Yep.
that the goal was to bring this more in line with PALS, because during training we realized EMTs and CFR don't take PALS, so it was not clear that they should ventilate these pediatric bradycardia patients before starting CPR, if they still had a pulse. So this is moving it in line with PALS, but not really otherwise really changing the medicine.
Any further discussion? Okay, hearing not, is there anyone who opposes these changes? Or is there anyone who abstains? Very good. So this can move to REMAC from the Medical Standards Committee for discussion. Is there any discussion from the REMAC committee members?
No,
I'm sorry,
David, let me ask you a question. This
I'm
looks
sorry.
to me like language changes to clarify, and it's not a change in any protocol. It's just clarification. If we all agree to that, we probably do not need to vote or send this to the state. We can just make that clarification.
Are these changes?
I
Are
don't think this is
these?
a change to the context. I think this is a change to the language. That's my personal opinion.
I agree, but Ben, maybe you clarify. Are these substantial changes compared to?
I don't know what you think. The previous protocol could be read as if you have a 5-year-old whose heart rate is 50, you should immediately begin CPR rather than starting with ventilation. When we had said, follow AHA, we had sort of assumed people would know to start with ventilation. So I don't know. A paramedic would say, no, this is not a change. An EMT might consider this a change in care. But I think you could argue it doesn't need to go to the state, but I don't know.
Yeah, I would say this is a clarification, as the original intent of the protocol was the same as this. You're just clarifying it.
I agree.
Okay, very good. So
In
we
that
will.
case, we can move it forward without a vote and just make that
exactly.
clarification.
Excellent. So Dr. Lai, the third item.
Okay, sure. The last one is going to be a change. So this one is going to be one that we will, I think, need to vote for. It will be adding a medication on here, as well as like some other clarifying statements as well. So the next protocol that we have for discussion is going to be the procedural sedation and sedation for advanced airway management for adults and pediatric patients. So you can see here in terms of like the changes that are made for the protocol that was approved last summer, we do have some changes to the definitions that we have here. So for procedural sedation, we have this as being we removed CPAP on here after some discussion from the protocol committee. I think historically from protocols that we've had in the past for this, that CPAP was, anxiolysis for CPAP was always sort of mentioned on there, as well as in the previous like difficulty breathing, and when CPAP was applied protocol, that it was stated that providers may use an anxiolytic for CPAP if a patient was not compliant with this. After some discussion at the protocol committee, we decided that just basically could potentially be just as a sign for hypoxia. So we wanted to remove the CPAP from the procedural sedation list. So you can see that is removed, so that only procedures such as synchronized cardioversion and transcutaneous pacing are listed on here as examples for procedural sedation. Otherwise, the next part, we just added the definition for the sedation for advanced airway management as being an analgesic or a sedative medication to perform or maintain an advanced airway. So that would be endotracheal intubation or the use of a supraglottic airway device. I think that having this, again, kind of going through some of the training aspects for it, we wanted to be able to encompass that this sedation protocol could be used both as an induction as well as to maintain an airway that could have been placed under different circumstances, such as like a cardiac arrest. Somebody could be waking up from a cardiac arrest, or somebody who already has the airway in place, and our provider would just be using medications, understanding orders for sedation, just to keep that airway in place for that. All of the criteria have remained the same as what we have used from last year. We added some language on here. This is just a language change for the pediatric patients, but otherwise that has not changed. This was language that was just taken from the GOP section that was already approved, I believe, 4 or 5 years ago. Just to reiterate that the continuous waveform capnography must be used whenever there's an advanced airway device in place, except for the cases where there's an MCI or other situation where there are insufficient resources available for the monitoring in place. Same language from the GOP section. So this section, we're hoping that this will be able to kind of clarify again what I said before, just in terms of the need for sedation, again, just for procedural sedation, as well as the sedation for airway management. Procedural sedation is listed on here. Again, CPAP is removed. The dosages have remained the same for procedural sedation, but it's just listed as such. For the sedation for the airway management, this was just slightly modified just in terms of kind of splitting up the sections so that one will be clearly for induction purposes in order to place an airway. And then the next step would be clearly for the sedation of a patient already with an advanced airway in place. The one addition in terms of the medication and medicine that has changed on here that was discussed at protocol is the addition of fentanyl on here as a standing order medication. The fentanyl, as you can see, can be used as a standalone medication option, or can also be used in conjunction with one of the other medications here as well, because there was discussion about, especially from the physicians, in terms of using fentanyl as a standalone agent, whether that would be enough for sedation versus, and we felt that at the end that I think with a lot of people's practices that they do use fentanyl, but usually in combination with another medication such as a benzodiazepine. So that was listed on here for the fentanyl, that they could use another administration of another sedative, may be considered for additional sedation on here. The other thing that was added was just some changes to some of the key points and considerations on here that there's a key point that's added that a medication may be administered to a patient to maintain an advanced airway, even if an induction agent was not used to place the airway, as well as the other one was just a language change just in terms of, in terms of like if a difficult intubation is anticipated, that a patient that providers should, if they can effectively ventilate with the patient, that they should consider just managing the patient's airway without another adjunct device on there, if ventilations are adequate on here. So that is a lot. So I think that, if there are any questions for this protocol. David, you're on mute.
Sorry. So a lot of thought and work has been put into changing this protocol and making it a workable protocol. And there were a lot of changes and discussions in the protocol committee until we came up with this final product. And I think it's a good product. Any discussions regarding this protocol? Yes. Who's raising their hand? I'm sorry.
I think Red Letter gave a thumbs. He gave a thumbs up.
Again, it was an expression of support.
Okay, very good. Anyone wants to ask, discuss anything? Very good.
Yeah.
Hearing none. Yes, go
David,
ahead.
I'm sorry, I couldn't find the hand function. Pam, just to clarify, for patients that are altered, telemetry will have to be called before they're intubated?
So for adult patients, they have to follow all of the criteria on here. They have to be altered mental status. They have to have a respiratory rate less than 10. They have to have their SpO2 less than 90% without supplemental oxygen. And they cannot have an immediate reversible cause of the symptoms. If an adult patient has all of these criteria, then a provider may use this protocol under standing orders. If they have something else that, say that they're not altered, but they meet everything else, they would then have to call telemetry in order to get the orders for sedation.
I see.
And this,
Okay.
by the
I
way,
was-
is and Lauren, this is unchanged from the 2021 protocols. This part of it.
Yeah, I was confused. I apologize. In regards to the respiratory rate, wouldn't it make sense to perform advanced airway management on somebody who is tachypnic versus bradypnic?
So again, so this protocol was sort of crafted, I think, I think that this was, I think it was a lot, I think, for our region in terms of for those of us who do provide online medical control, who is going to be like that patient that we would absolutely say that this is going to be a patient that you would not deny medical control orders in order to do induction as well as sedation for a patient. And I think it was like, this is the first time that we're having this understanding orders. So after a lot of discussion at the protocol committee, we had kind of come up with these criteria in terms of, with the input of a lot of, telemetry physicians to say that this is going to be the one patient that we would never deny. I think that you can make some cases, I think, for people like outside of this criteria. And again, I think that initially when this protocol was first proposed, we did want to be a little bit more on the conservative and more cautious side, implement this protocol, I think, and then perhaps to see if we don't have any bad incidents in terms of our providers using this protocol understanding orders, then I think that we can expand it to, I think, a lot of the cases where it's, just as you said, somebody that's going to be super tachypnic or have other loosening of this criteria. But I think the original intent was to have somebody specifically fit all of this criteria and then have that person go understanding orders.
Understood.
Absolutely.
Would you be opposed, Pam, to adding something like a respiratory rate greater than 40, which I feel like is also kind of extreme and conservative, but in the other direction? Or would you rather just keep it at bradypnic for now, rolling out?
Lauren, hold on. Can I suggest, please, that we vote? This is vote a second in motion to the committee right now as it is. The first time that we allowed sedation for advanced airway management understanding orders was in the 2021 protocols. This is how it was approved in the 2021 protocols. We can definitely bring it back to the protocol committee, Lauren, to discussion and to change or add to these criteria. But I would not do this right here, right now.
Okay.
If you're okay with that.
Yeah. Sure, no problem.
Okay.
I agree.
Any further discussion about this protocol, both from REMAC members and medical standards members? Okay, hearing no further discussion, we're gonna vote. So anyone in the medical standards committee opposes or abstains from approving this protocol as it is? Okay, hearing no abstentions, no one is opposing, we're gonna move to a roll call to the REMAC committee members. Marie.
You want a roll call vote for this?
It would be for
REMAC.
Marie. So
this is for REMAC.
It's coming as a second in motion from medical standards to REMAC at this point.
Okay, hold on then. That I could do. Okay. Okay, and I apologize. Which protocol is this? This is sedation for advanced airway?
This is procedural sedation and the sedation for advanced airway management.
Okay. Okay. This is physicians only from REMAC. Please respond in favor, oppose, or abstain. Glenn Asada.
In favor.
Bradley Kaufman.
Favor.
Dario Gonzalez.
In favor.
Nathan Reisman.
In favor.
Pam Lai.
In favor.
Nicholas Alexandru. Doug Isaacs.
Favor.
Jeffrey Raybridge.
In favor.
Reed Caldwell.
In favor.
Louis Marshall.
In favor.
Michael Redlener.
In favor.
Okay. Arthur Cooper,
In favor.
Mark Cantor,
In favor.
Robert Crupi,
In favor.
Mary Foote or Timothy Stiles,
In favor.
Laura Avicoli,
In favor.
Wallace Carter,
In favor.
Kevin Munjal,
In favor.
Matthew Harris. Not here tonight. Ben Zabar,
Approve.
Paul Barber,
In favor.
thank you. David Benelli,
In favor.
Peter Wire.
In favor.
Okay, that's unanimous in favor.
Great.
Okay. Thank you, Dr. Lai. Anything further from the protocol committee?
No, that is it. The next protocol committee meeting is on January 28th.
January 28th. Perfect.
Yes.
Okay, other subcommittees. So the interfacility committee, John is not here. So he will give a report in the next meeting. The Ecmo committee, I will just give a very brief summary of what's going on. So we have made significant advances with AHA. They have agreed to provide the project management for this. Michael Redlner gave a fantastic presentation to a national AHA committee, the coronary artery disease work group. That was on Thursday, December 6th, and we received strong support from this group to proceed with our project. And Michael and Dr. Tanis Holland, she's an intervention cardiologist from Mount Sinai, and myself are scheduled to meet with AHA at the national level on Friday, the 14th, to see how we can translate this into actions. Prior to meeting with the five participating Manhattan pilot hospitals, we are going to hold meetings with sympathizers who are ECMO physicians who are sympathizers from those hospitals to get from them feedback, input prior to the meeting. We have identified a number of those in Northwell, in Mount Sinai, and NYU, and we will proceed from there. Very interestingly, in the CMAC meeting in the beginning of January, the region of Monroe brought a ECPR protocol for approval for their region. Essentially, they're going to be transporting potential ECPR patients to 2 EDs and start ECMO. So obviously, it's a much smaller region, but that protocol was approved by CMAC. And essentially, it's really paving the road for us to continue with our pilot because they already crossed a lot of the hurdles at the state level. So the ECMO tag meeting is going to meet in the beginning of February. Hopefully, prior to REMAC, a date will be sent out. I think that with that, we're going to end the medical standards portion of this because we have to go into REMAC. So is there any new business? Oh yeah, Ben, you want to bring up new business. So please go ahead.
For I think it's for medical standards, the medication.
Yep. Sure, go ahead.
And so, I mean, this came out of a discussion with protocol, but I think some of the thinking was it's probably more for medical standards. As prefaced by saying the goal is not to require anyone to carry a new medication they're not carrying. But there was a discussion about what is the minimal medications required to have on an ambulance or on a unit. And my understanding was generally, you need to be able to do all the required protocols at your level, which means all the standing orders, unless there's an option, one or the other, you have to have one of those options and at least one of the medical control options. But one of the exceptions to that is potentially there's some protocols now, like the WMD protocol and smoke inhalation cyanide, where, correct me if I'm wrong, but I don't believe the volunteers are currently carrying WMD kits or hydroxycobalamin, and that is not the goal. But I don't think we can simply say, if it's in standing orders, you have to carry it, because that would force the volunteers to carry those medications. So my suggestion to medical standards is to make a motion that basically says, with the specific exception of smoke inhalation, cyanide, and WMD, and the exception of medications that say, if available, you have to carry the medications to do the standing orders and at least one medical control option, at your level, or however that's phrased. And I don't think that would make anyone carry anything new, but it would make clear what is required and what's not. That's my suggestion.
Okay, so Ben, that your suggestion is to, can you just say again what you're suggesting, so we can all
I'm not
discuss
a
this?
medical standard, so I can't make a motion. But to say the medical standards and the REMAC requires that units operating under these protocols carry the medications to be able to do all the standing orders, and at least one of the medical control options for each protocol, with the exception of medications that are listed as if available, and the exception of the medications in the WMD protocol, the cyanide protocol, and the smoke inhalation protocol. That would clarify what's required and what's not.
Let's open this up for discussion. Dr. Isaacs.
So Ben, just a clarification. So we made it if available for the hydroxycobalamin, some of that sulfate, because of the pre-hospital, all pre-hospital units. That's why we let if available, but for the 911, it's contractual that the 911 units must carry it. So just so everyone has a full understanding, that's also includes the WMD kits that the 911 participating units must carry. So just so everyone understands that difference.
Right. Yeah, exactly. Because at the protocol, there's some work that's being done on a list of all the medications. And because I think people have felt that those two protocols are really referred to 911, but because the protocol doesn't say if available, if you said every unit must be able to do every standing order, that would therefore require volunteers to buy those medications, which is not the intent. So that's exactly. So 911.
Yeah, that's why the if available is in there for that.
I don't think it's the 2022. I don't think says if available.
David, I think
Dr. Raybridge. Yes, Doctor. 1 second, Joe.
Thanks, David. I just wanted to clarify that. My understanding was, unless it specifically says if available, you otherwise have to carry it. So I don't know that it has to be that wordy that, you have to be able to do all the standing orders in one medical control option. I think, if it doesn't say if available, with the exception of the WMD, if it doesn't say if available, then you have to operate in the 911 system. You have to be able to do all the standing orders, right? Already. Isn't that already the case?
Yes. For 911. Yes, but the protocol committee was considering or putting out a list of all the medications, and I don't know if this is going to happen or not, but there's a suggestion to indicate which ones were required, which created a conversation of, well, what is required at the REMAC level, not 911.
So part of the discussion was that Brad was preparing a formulary, and there was a discussion of how extensive and how detailed the formulary has to be. And that's a separate discussion. Dr. Shanker, I think you have a suggestion.
Yeah, so two things. First of all, the formulary already exists at the state level. I don't think we should rewrite that formulary. It's actually pretty well written by the state in terms of medications. I think a list of what medications are required and not required is a good idea. But again, I think that all of this is part of a much larger conversation. I think that, when we talk about a single patient in a house fire, do we want a volunteer that is on that scene to be able to provide that treatment versus a WMD where FDNY is the managing agency for a MCI in that situation, and therefore the contractual obligation that all 911 participating units have would supersede, and the fire department can say, you need to carry all of this stuff, whether it's if available or not. I think the if available language clarifies that. So if an agency really can't afford it, they can get around it. That said, I think we also should really look at this and say, do we believe that this is something that an ambulance should have that's responding to an emergency? I think that that is something we really need to look at. It's a bigger question than this one line that Ben is talking about. I think it's a bigger question as to what we feel should be required and what we feel shouldn't be required. And I think that that's where this really boils down to. In the end, I think the little word of if available for the ones that we don't think are required, but maybe we write suggested or recommended so that a volunteer agency that has a few extra dollars will buy a cyano kit and have it for that one house fire patient versus, the WMD kits that are for these mass casualty incidents that we hope never happen, but the fire department will be the lead agency on that. I think that that's a better way to look. It's a bigger question than do we want to add this one language through a motion right now.
Okay. Is there a so Ben can't actually motion because he's not part of medical standards. Do you want to bring this for discussion, Ben, in the protocol committee, which you are a member?
Yeah, I mean, not to speak for Pam, I think there's a question of is it the place of protocol committee to decide what medications are required? Because it's not, the medicine is, that's why they're in the protocols. It may be, but however you and Pam want to go, divide up that work, that's fine.
So Ben, I know you were going to make a motion or ask somebody to make a motion. I would suggest that we put together a group. I know that Brad is working on this to go over the medications and figure out what we believe are required medications and what we believe are not. Protocol has a lot on their plate. They're developing the protocols of how we use these medications, but I think we should start with a small group to go over that list, figure out what we think are required, what we think are strongly recommended, however we want to word it, make that formulary for this group, bring it back to medical standards and REMAC, and then discuss it that way. I think Pam is right that this is not a protocol question. This is a larger picture of what medications we feel should be required or not required in our system. So I'd like to make let's call it a medication tag that will review the medications that we currently have and decide what should be required, what is strongly recommended, and what is if available. And if we put that in a medication table, I think that would clarify and make the protocols a lot simpler, and it also keep it all in one location, maybe easier to keep track of. If that works for everybody, I'd like to move forward with that, if that's okay.
Okay. Any further discussion about this? So, Ben, you will.
Anybody's interested, whoever is interested in participating, please email myself and Marie, and we will set up a meeting for the next 2 to 3 weeks.
Very good. Thank you very much. I don't think there's anything further. Is there any other new business on medical standards? There's no other old business. Very good. Motion to adjourn there's no need to adjourn. We'll just move this further to.
Okay, so again, it's now 6:47. I'd like to be done by 7:15 the latest. So I will move to QA, Dr. Redlener.
Good evening, everybody. The QA committee, the quality committee met on December 8th, and we discussed several items. The primary item that we discussed was the 2020 quality project that we'll be embarking upon. This is building on the work that we did all throughout the year last year related to the Mission Lifeline measures for STEMI and stroke. We've done a lot of work related to this project to develop a change package. We've identified three areas that we'd like to focus on. One is glucometry and stroke. One is time on scene for stroke, and then time to 12 lead EKG. And we've come up with some ideas about how to make some changes that not every idea will be applicable to every agency, but we've made some suggestions. And Joe Ranieri, if you're online, I think that we have that document available. If it's not available quite yet, it will be available very shortly to talk about some of the specific interventions that we'll recommend for agencies to take. The other piece of that is tracking the data over time. We've been working with First Watch and First Pass to improve the availability of data and the presentation of data for the region. And I hope to be able to present that at the next REMAC, but working on some updated, improved way of displaying data with the focus from our quality project. So that is also in the works, and I hope to bring that to this committee. There was discussion about a research study that a PhD student wanted to give to the region. There was a question about how that should be vetted. It wasn't necessarily felt to be most appropriate for the quality committee, but something that should be, we should identify how we're going to allow research projects to move forward in the region related to external folks. I think we talked about the idea of a research committee or another committee that's going to approve or deny, like a surveys being sent out. So that was the discussion of the committee. We are rescheduling the timing of the committee. We're going to postpone what's on the calendar for Wednesday, and based on doodle poll results, we'll send out a new invite for the members. Thank you.
All right, any questions for Dr. Redlener? Okay, hearing none. Training and education, Mr. Lax.
So TNE has met numerous times to get the training over the finish line. We met a couple of obstacles that were all technical. Biggest one probably being that the DOH did not put it on Vital Signs Academy. So that was probably the biggest delay. And so we scrambled last minute and got it put up on REMSCO's LMS, which is less than ideal, but was nevertheless a mechanism of getting it out there. So the information is out there, it is available. They're not built as they would be in a typical LMS, which leads us to the next conversation, which is our search for a more robust LMS that is more up to date and capable of handling what today's educational standards really need, similar to what most of the schools are using. So that search is going on. I've discussed with Dr. Kosterko coming on, and she agreed to training in ed, since we do not have a physician on training in ed. So I think that will tremendously enhance the work that we do. We are also looking to add much more regular classes for the upcoming year, boost up CME opportunities, especially on the call review side, and hope that the folks on this committee can help pitch in some way every now and then, so that we can push things out regionally. It doesn't have to be anything special or going out of your way to do anything new, but if there are things being done at your agencies that potentially we could utilize even after the fact in a recorded fashion or something like that, that we might be able to put out there for the region, especially with things being still done quite often virtually nowadays. So I will just put that out there. And that is in essence it. There is a CLI class coming up, and the state did finally approve some more regional faculty. So that's where we're at. Some progress.
Great, thank you. Any questions for Morty? Okay, hearing none, let's move to the REMSCO report. I know you did just not here. Bob, can you cover that?
So CMAC and SEMSCO met on January 4th. It was a virtual meeting. It was somewhat abbreviated because it was virtual. At SEMSCO, there's no chair's report. There were elections. There was a slate put forward and nominations taken from Floric, and Mark Philippi was reelected as chair. Mike McFoy is vice chair, first vice chair, and Jason Haig is second vice chair. Ryan Greenberg spoke. He spoke about staff deployments to the vaccine sites. Also some EMS deployments of upstate New York City, and Hudson Valley. He mentioned operations, okay, that there be updated policies that would soon be posted. He didn't actually mention what those policies were. There was mention of an EMS advisory committee actually meeting today on January 11th. Dr. Brian also commented that the PCR portal has been a success and working very well. He wanted to also thank everyone who participated in having a successful meeting. Vital signs that there were 530 people in person who attended, and also 300 virtually attended. The next year would be in Albany. There's also a reminder, on May 17th, that will be the 2022 Ems Memorial. There's also a discussion somewhat lengthy about EMS providers in the state, that only about 40% certified providers are actually providing care. Again, they need to try to find ways to get them back into the EMS system. Part of that was a discussion about creating more opportunities to work in non-traditional roles, and was thinking that this might be a way to bring people back to the system and maybe encourage longevity within the field. Then there was the presentation of CMAC protocols, which were all approved. But before we got to that, Hector Langston was actually appointed the parliamentarian for REMAC, which everyone was happy to sign off on to keep our meetings productive and orderly. Then the protocols that were discussed, one we actually mentioned in some detail here already, the viral pandemic response protocol, which was first in effect in March 2020, that there was some modifications made, that was not valid until activated by the REMAC and will only remain in effect for 14 days unless renewed. Again, was mentioned earlier about some changes such as taking the temperature out of the assessment. There was a review of the criteria for non-transport, or treatment in place, and whether or not medical control needed to be involved. Was really up to the region. And I also had mentioned earlier that Jeff Raybridge had asked Ryan Greenberg if he could please, bring this to the attention of the commission, DOH commission, as soon as possible to expedite approval, which Ryan agreed to. And then there were some protocols were mentioned in different parts of the state. There's a pediatric study up in the Buffalo region, a multi-center study involving EMR, looking at midazolam, pre-hospital procedures, using an age-based approach for dosing rather than weight-based. It's a 5-year study. It was approved. There was another protocol for buprenorphine for acute opioid withdrawal using the opioid withdrawal scale to be used by certified physicians, certified for medical assisted treatment. In another region, had a protocol reviewed and approved for refractory VTAC, VFib, to bring patients to Ecmo centers. And that's probably it in a nutshell. I skipped over something that someone wants to bring up. I know a number of you were at that meeting.
Jeff, anything to add?
Nope, those are the major points that were covered. The only thing I'll add is there was a discussion, and it came up with Monroe Livingston's advisories as to the authority of REMACs and issuing advisories that may look like protocols. And the CMAC and SEMSCO were extremely supportive of the REMAC's authorities and REMSCO's authorities on this, and pushed back against the health department a bit on that. So I think that was a good sign that most of the regions were, in support of the idea of regional control.
Yeah, I think that's very important considering the state of the state address that the governor came out with, which clearly indicates that part of her agenda for 2022 is to streamline EMS through the state. And it almost reads as if the state is looking to remove the regional level of authority via legislation. So I would advise, recommend to all of you to really reach out to any legislator that you know or that you have any relationship with, and strongly voice your opinion about the importance of regional EMS control, especially considering that as a region, we have one of the largest concentrations of EMS physicians and EMS resources in the state, obviously, and it's really important that we do have the ability to manage things locally rather than just via state. I think that what applies in Rochester and what applies in Buffalo doesn't necessarily apply in New York City all the time, even though the medicine is the same. So I think that's really important that we do stay on top of that. I know that that's something I'm going to be very aggressive about this upcoming year. We did not have I think the REMSCO meeting for January is next week, Marie.
Yeah, I have the report from last month if you want me just
Okay,
to
you
read
want
it.
to give that and then we'll hopefully wrap up.
Sure.
Joe, question.
Sure.
Wait, I believe that there was some discussion. People wanted to say something before the REMSCO report.
Sure.
Brad,
Before
go
what?
first.
Yeah, so Joe, I just wanted to stress, I think exactly what you said. It's important. I mean, that was concerning that that's being pushed as to really eliminate what would effectively eliminate our REMAC. And I think it's important, as you said, to reach out, but I think we should actually more formally, make our wishes clear with a letter to the Commissioner of Health from our REMAC, or in some more formal way than in addition to everybody reaching out.
No, I think that's a great idea, Brad. I would even add the governor on the email on the letter like that. I think it's important that they see at the state level that this is a very important part of the governing body of EMS in New York State. And even if they choose that, if they feel that the other REMACs do not have the breadth to manage their regions or their counties or whatever you want to call it, in New York City, we have a very robust system, and it is important that we maintain our control, because I think that what our needs are not the same as the rest of the state always. Paul, you have your hands up, and Doug, you have your hand up. I apologize for missing that before.
My question's a little different. So Doug, if you want to talk about this again, I'll digress.
Yeah, no, thank you, Joe.
Doug,
you're breaking up. Maybe just shut off your video,
issue
Doug.
for us this year. It's been an ongoing battle. I would like to emphasize that better.
Doug, turn your camera off. You're all broken up.
I turned it off already. Thank you.
Oh, it's still frozen. That's
Can you
why.
hear me or not?
We hear you now. That's better.
Yeah.
Okay, I was just saying, Joe, thank you for articulating the issue really well. This can be hot button an issue and has been for the last 2 years with the protocols. I just want to reemphasize, representatives for us really and our voice has spoken as a region to support.
I think we lost him.
Yeah, we lost him.
Yeah, it looks like we lost him.
All right, I'm assuming that he'll try to get back on. Paul, do you want to say something, and then we'll?
Yeah, from the CMAC
Doug,
report, was there any?
Doug's back. Doug, are you there? Or not?
Yep.
Not yet. There's no one in the waiting room.
No, he's in.
Was there any discussion with the state EMS medical director?
There was a discussion at the CMAC. I
Yes.
think that it is being discussed, and I think that's part of Don's meeting. with
Right. So the letter was sent and the meeting request was granted, and it's going to be brought up at the meeting as well.
Yeah.
Excellent.
And the other thing I can add to that is I know that both New York ASEP and New York NAMSP in conjunction sent a letter supporting that letter.
Great. That's great.
Like I said, I do think that there is an importance to a state EMS medical director. I do think that there's also a strong importance of this region maintaining some modicum of independence just because of the size of our region and the requirements operationally that are very different than the rest of the state. I think that has to be involved in the discussion at every level, because I think this pandemic did definitely show that we need to be able to make decisions sometimes faster than a state can make those decisions. And we generally set the tone for the rest of the state just because things happen here first. Nothing against anybody else, but that's just what happens.
Joe, I didn't want to mean that those things were mutually exclusive. I'm totally in agreement with you 100%. It was just, Two different points at the same time. I apologize.
Got it. Thanks, Paul. Doug, are you back? All right.
So Joe, how do we leave
I am,
it?
but
Is the
don't worry about
REMAC,
Okay, I'm sorry. Go
is
ahead,
REMAC
Brian.
gonna send a letter?
Yeah, I think REMAC will send a letter if unless there's any opposition to that. I think we should write a letter to the commissioner and the governor stating the importance of regional control as part of a statewide EMS system as supported by Article 30. I think that should be. I will draft some language. I will send it out to a handful of people to review because my writing is not the best in the world. And then we will process that and get it out there.
Great.
Joe, I don't want to beat a dead horse, but I really want to support that. And I really think we need to do that. I think it's extremely important. And I'm just going to end it there. And we really need to move forward. Waiting for a Ryan or a medical director or commissioner of health to think of doing something is the wrong way to go at EMS. And I don't think they realize that. We really need to pivot a lot faster, and we've proven that we can.
I agree with Dario. They don't know what they're doing.
I'm wondering if the medical director discussion prompted this. That's where I was going.
I mean, I think the discussion at the CMAC, for those of you who were there, for those of you who weren't, there was a discussion about other regions trying to figure out how to implement things and what has to come to the CMAC, what doesn't. That really prompted a large part of the discussion and a kind of a reaffirmation of Article 30 as it stands today as part of the discussion. And I think that that's something that we need to make sure is clear and make sure that the State Bureau of EMS is aware and remembers is how it's built.
Yeah, Joe, this is Lou. I think that also we need to think about other regions have an EMS medical director for the region, right? Where we have a REMAC and REMSCO, others have a medical director for the region that helps make decisions in between meetings, and it really directs how things go. So I don't know if that's something we want to consider or not, but
so I remember that conversation came up at medical standards and at
Yes, with the
CMAC,
pandemic
and I think
protocol.
one of the things that one of the advantages that we have is the large amount of EMS physicians that we have in our region. And thankfully, we have a REMAC that is very active with an active executive committee that essentially takes the role of that regional medical director so that all sectors are represented. And it is a decision that's made not in a vacuum by one person, but rather by the appointed leadership of this group so that we can operate as one. And I think it actually has worked very well. And I think that that's one of the things that came up, that I felt came up at medical standards that is very important for our region. I don't know that we specifically need a regional medical director because we have an executive committee that can on a dime, and we did that this week, get on a call and respond if necessary.
No, I agree with you. Definitely.
Okay. Any other comments? I saw Paul's hand is up and Ben's hand is up, and then we'll try to
Just
wrap.
that this is something that the hospitals need to value as our hospitals do. We've gone out there to say that this is an important thing and an important part of the healthcare continuum. There are 4 training programs for EMS physicians in this state and several in other places that are close by in neighboring states. If the EMS physicians aren't here, then the hospitals need to do better at luring them in. It's really contingent upon them to not throw their hands up and say they don't have the docs, they don't have the knowledge. We are training the people. They're just going other places. Ask yourself why.
Good question. Ben and Doug. I saw Doug, you had your hand up as well. Ben?
I would just say in the letter, we may want to emphasize that, there already is state level collaboration, that we, adhere to the state required BLS protocols, and, we, through the CMAC, coordinate through with all the other regions in the state that, which the governor may not be aware of, but that, like you said, we need some autonomy.
Correct. Doug? Okay. All right. I think that concludes all the committee reports. Is there any new business. I think
Yeah.
old business,
Hey,
we
Joe.
covered new business. Doug, go ahead.
Yeah, I'm sorry. I think I cut myself off. Just real quick, I don't want to get off. Just for the technology equipment tag, we're now the new year. We're going to try to kick off a couple things. So probably for end of February, March, we're going to have a first meeting and then another one by June. So we'll have something set up, probably sent out the next 2 weeks, and we'll pick a date, and we'll probably host if we can at Fort Todd and if we have the space. So
great. Thank you.
More to come.
Okay. Ladies and gentlemen, I thank you for this, for everybody's time tonight.
Motion adjourned.
Yeah, I'm sorry.
Motion to adjourn.
Motion to adjourn.
Second.
All right. Have a great night,
Play
everybody.
the Oscar music.
Yeah.
Have a good night.
Goodbye.
Thanks. Good night.